right? And again, the EKG practice, you want to, these are, there's a lot of different definitions. Basically, all these ones are ST elevation of some sort. And you're going to identify, and all the EKGs were yoinked from the previous slides. There's nothing new that so if you like matching things, is for you. Or ideally, you want to try to work through the different problems here, right? There's just another way to look at it so that you can recap what we've been talking about. Okay, so you're going to tell me what kind of MI it is. Is it anteroseptal? Is it inferior wall? Is it a posterior wall? Is it a right ventricular MI? Is it a, what kind of MI is it? And what vessel is it? What do you think the cath lab's going to stent? Are they, because they have how many minutes to stent? And to open up, it's kind of this door to balloon, right? So door to the time where they balloon open up the artery, right?
90 or 60.
You got 90 minutes, right? Usually our in LA County here, our goal is 60 minutes, right? Just because we'll get judged by the hospitals. Look at Palmdale, they're at 63 minutes, right? So, but it's under 90 minutes is ACLS guidelines, right? And then reciprocal changes. So you're looking, because that's going to confirm that you have that MI, right? So are there reciprocal changes or not? And then do you need to assess if we need to do a posterior wall or a right ventricular wall assessment? And how do you know you need to do that? When would you want to get a posterior wall evaluation? Good. You have ST depression on your hands, and ST depression is located where?
On the E1 and 2.
Good. V1, V2, maybe V3 too as well. But yeah, you see in your precordial leads that are on the front of the chest, you're seeing ST depression. Well, the reciprocal change would be on the back, right? That's where you're going to see the ST elevation. So we throw the posterior leads on when we see V1 through V3 ST depression. Okay, and then V4R, right? When do you want to get that? Throw a lead right here on the right side of the chest when you have looking for an RVMI. But when is that? Why would you say, oh, let's do this now?
You have an elevation, the AVR?
AVR, no, that's going to be like there's only 12 that you can do for that. That means the whole system's down, right? But yeah, it makes you think of RR, yeah. But no, it's when you have 2-3 AVF ST elevation, right? 2-3 AVF ST elevation means my RCA is compromised, right?
Oh, so you're just going.
So we're looking up here. So we have our RCA coming off, right? RCA coming off my aorta there, and it's going to then have a few branches. RV, right? Inferior wall, and then lastly the PDA 80% of the time, right? So if I have a 2-3 AVF ST elevation, I want to make sure that I don't have a blockage more proximal, because 40% of the time it could be proximal.
So then V4R is just to see how high.
It's going to assess it, because there's no, when you do the standard 12 leads to assess for an MI, it doesn't assess for right ventricular at all. There's no way to tell. But what can clue you in is that you have 2-3 AVF ST elevation, and then you throw a V4R on, and that's going to look right at the right ventricle and see if the RV is impaired,
Gotcha.
right? So yes, 2-3 AVF are impaired as well, but it's proximal. It's the RV that's involved. Okay. All right. So let's split up and do some questions.
Okay.
All right. So we got number 1 in the top left corner. What do we have for this one?
I think it's pericarditis.
Pericarditis. You do have some AVR ST depression, but we got to look elsewhere. What else is going on?
2-3 AVF elevation.
So 2-3 AVF have ST elevation, right? If you have reciprocal changes, that like ups your odds from just like, oh, maybe this lead placement error to like that's an MI.
Yeah.
Are there reciprocal changes?
1 and 2, yeah, or 1 in AVL.
Mm-hmm. Yeah. So 1, yeah, a little bit. Yeah, AVL for sure, right? So you have reciprocal changes, and you're from your inferior wall, right? So what kind of MI is this?
Inferior.
So it's an inferior wall MI, right? So 2-3 AVF I have ST elevation with reciprocal changes and 1 in AVL. Therefore, this is a inferior wall MI, right? So I mean, with an asterisk, because it might be something else might be going on too, right?
I do see elevation at V1.
Yeah, that might just be lead placement error,
Okay.
right? So they might put the V1 a little bit too low, looking directly at the inferior wall, right?
I saw some
So Yeah, because remember, it has to be contiguous leads. So yeah, I do see a little bit of ST elevation there, but it goes away. So in V2, I don't expect that to happen, right? It needs to be contiguous. It needs to be 2 or more leads. It's how you define an MI. And then when you have reciprocal changes on top of the MI, that's like puts your odds all the way up like 95% at least, right? So that's inferior wall MI, and what vessel feeds the inferior wall? The RCA, right? So the RCA is blocked, but remember I told you, what if we have blockage up top, right? Could the RV be involved? It definitely could, right? So we would probably do a V4R to see if the right ventricle is affected as well. Otherwise, it's just the inferior wall of the left ventricle. All right, are there reciprocal changes? There is, right? Reciprocal changes in one AVL. We got ST depression, well, yes, in AVR, but we got ST depression in one AVL, and we have a ST elevation in 2-3 AVF. And do we need to do V7 to V10 or just V4R?
I mean, we should.
So the only time we do V7 to V10 is if you see posterior wall changes, right? Do you see posterior wall changes? What are posterior wall changes? No? Posterior wall MI is when you have V1 through V4 maybe, but usually V1 to V3 if you see ST depression in V1 to V3. That's a red flag for this might be a posterior wall MI.
So is there depression on V3 there?
That's, you could arguable, I don't think so, right? V1 through V4 has ST depression, that is considered a posterior wall MI until proven otherwise.
That's pretty dramatic depression. Pretty dramatic depression.
Depression, right? That's V1 has a little ST elevation,
Yeah.
but V2 does not have ST elevation, or I mean maybe like 2 millimeters.
Okay.
But we're looking for ST depression, right? Something like that. That's super. If your V2 looked like AVL over here, I would say that would be a posterior wall. Okay.
So you're pretty high. I mean, you know what the answer is, but.
So yeah, I mean we have reciprocal changes. That is what tells me it's inferior wall, not posterior wall. But yeah, could there be blockage? Yeah, because 80% of the time the RCA feeds the PDA. But in this case, it could be the left circumflex that feeds the PDA. Okay. So RCA, inferior wall MI. And yes, we should do a V4R to assess. Posterior won't hurt, but there's no signs of it, right? All right, next one, bottom left. What is this?
We did a high lateral.
So good. So we have high lateral, you're saying. So we got one AVL of ST elevation. Are there reciprocal changes?
In 2-3 AVF.
Yeah, there's 2-3 AVF have reciprocal changes on the other side. So when you have reciprocal changes, that pretty much confirms that you have an MI, right? So we have, and that if that's one AVL that are elevated, then that means we have a high lateral wall, MI, which means that what vessel's involved?
The
CX?
Yeah, the circumflex, right? Yeah, left circumflex is redundant because there's no right circumflex, but it's okay. I say left circumflex all the time. All right, so yes, the left circumflex is affected, right? It has blockage. Therefore, what else? So vessel left circumflex, MI is we said high lateral wall, and then reciprocal changes, yes. And then do we need to do a V7 to V10 or V4R?
I think there's elevation on 1, 2, and 3.
There's elevation, but is there is there depression that would tell you need to do a posterior wall?
Gotcha.
So I mean, it's not going to hurt, but because we know the left circumflex 20% of the time can feed the posterior wall, but it's not absolutely necessary right now. Okay. So you do have anterior lateral wall changes, but I would say this is more, yeah, because V4 to V6 might be on breast tissue. But I would say it's definitely left circumflex. You can argue they do have ST elevation here, right? Which I think you do, right? So this could be a higher lateral wall. A lateral wall is like all the way at the end. So if we look at our left circumflex coming off, right? You have left circumflex, and you have LAD, right? You have little obtuse marginals, you have little diagonals coming off the aorta there, right? But what if we have a blockage all the way up here, right? I think that's what we're seeing. We're seeing that where you have left circumflex is definitely involved, but also we have the LAD involved because we have definite ST elevation in V2, V3, right? So yeah, I mean, this is a really, really high grade MI. So it has a lot of changes going on. I mean, you're not wrong to say lateral wall. They're still going to go into the left system first. They're going to go in there, and they're going to see real quick which one's the culprit lesion.
Gotcha. So if it wasn't redundant and we did get like a 7, 8, 9, those would be reciprocal. Like, so we would assume we would see depression because of the V1, 2, and 3 elevation.
Yeah, you would see ST depression in V1 through V3 if you had posterior wall changes.
Okay.
All right, what about the next one, top right?
We did anterior septal.
So anterior septal.
Yeah.
All right, so yeah, good. So we got some ST elevation, definite right there, kind of resolves right there, right? So V1 through V3 have ST elevation. So this is a anteroseptal wall MI. If it was just septal, which is very unique, you just see a septal, usually it's the one vessel is being blocked, right? And what vessel is that? Yeah, LAD is being blocked because the LAD feeds the septum, right? It also feeds the anterior wall. So there's an anteroseptal wall MI because the LAD is occluded. And then do we need to do a V7 to V10 or V4R EKG? No, there's no involvement in the left circumflex. There's no involvement with the RCA. Really, we do if we had the RCA involvement, we would do both, right? Because we know that 80% of the time it feeds the PDA, 100% of the time it feeds the right ventricle, right? And then we don't have to do a V7 to V10 because the V1 to V3 are elevated, not depressed. Okay, that's what we say here. So we got LADs involved, right? Reciprocal changes, no, because you're not really going to see very many reciprocal changes in V1 to V3. You might see it if you throw the leads on the other side. You'll see reciprocal changes on like V7 to V10. You might see reciprocal changes because it's on the opposite side. Okay, all right. So what's next? Bottom right. So you got some ST elevation right here, right? 2, 3, and AVF. Do you have reciprocal changes?
Yeah, there's
Yep.
like
Yep. AVL looks pretty reciprocal. And then what else? Do we have what kind of MI is this?
inferior.
Yeah, it's inferior wall MI, right? What vessel is involved? The RCA is involved, right? The RCA feeds the inferior wall. No other vessel does. Okay, and then are the reciprocal changes? Yes. Do we need to do another assessment for the posterior wall or for the right ventricle?
I would say I see some depression on AVR.
AVR, remember, we don't really worry about AVR until it's important. All right, that's something we look at last. Or and yeah, there's not really ST changes there in AVR anyways.
Okay.
And then if we had V1 to V3 ST depression, then yeah, we consider posterior wall, but I don't see it there, right? And then but we probably should do a right ventricular wall to see if it's up top, right? If it's happening up top, a little more proximal occlusion, we could have the right ventricle involved. We don't know what this patient looks like. We're just looking, just like ABGs, you don't know what the patient looks like. You just look at the numbers, kind of assess what it might be, what's going on. Okay, so yeah, this is a inferior wall MI because the RCA is occluded, but it could be a proximal occlusion, and the RV could also be involved. Okay, so inferior wall MI, yep. So AVL is the one that has the reciprocal changes. Okay, and definitely do a V4R. Posterior won't hurt because, I mean, there's no changes there, but you can't always guarantee the operator is correct, right? Because V1, V2 need to be in the right spot, right? They need to be right from the border, left from the border, and sometimes they got different ideas about where the V lead should go.
So is AVR looking, sorry, I'm looking at this picture right here.
Mm-hmm.
So is AVR technically getting like a posterior shot, or is it right over the...
AVR is not looking posteriorly. So when you look at your limb leads, they are doing not a coronal section, but a transverse section through the heart. So they're splitting the body in half, right? So limb leads look at if you split the heart in half, they're looking at that. They're looking at either the inferior wall here, or they're looking at the top of the atria back over here in AVR, or they're looking at the ventricles over here.
So
whereas their V leads, your chest leads, they are looking through the heart. So if we have V1 changes here, like ST depression on the front, if I put a lead in the back, I'm going to see the ST elevation, right? So the chest leads are unique in that fashion. They actually look through the patient.
So AVR would be looking at the right ventricle.
AVR is not looking at the right ventricle. You'd think it would be nice if R and R right ventricle would line up, but no, it doesn't. AVR is looking at the top of the heart. It's looking at the right right atrium, and the closest P structure is the right atrium. Okay. But the LV is going to be given all the electricity it's seen. It's seen all the electricity actually go away from it, and so if you're RV, you imagine you see electricity going down and away to the left, right? Okay. That's what the RV is seeing. That's what AVR is seeing.
Okay, gotcha.
Okay, but it doesn't see, like, if it was looking at the posterior wall, it's not looking at the posterior wall because the posterior wall is back here, right, on their back. All right, so yeah, so that's our inferior wall MI. All right, top left, what do you got there?
High lateral MI?
High lateral wall MI. So that means we see what? We see some AVL changes, we see 1 changes, right? We see ST elevation. And then anything else? We got reciprocal changes.
I'd say depression in 2, 3.
Yeah, so if there's ST depression, those two guys, they'll change hands. If one of them's elevated, the other one's depressed. And if the other one's elevated, the other one's depressed. So that confirms whether you have a lateral wall or an inferior wall MI, right? So this is, which one did we say? It is a lateral wall MI. And is it high lateral, low lateral? That's where we look at V5, V6, right? Because we know that the circumflex comes off the heart, right, of the aorta, right, comes off because you have the circumflex going this way, you got the LAD going this way, right? So here's our left circumflex feeding the high wall, and we also have the obtuse marginals feeding the low wall, right? Our OMs feeding the low wall. So the high wall is seen by which leads?
The high wall is 5.
By 1 AVL, right? 1 AVL see the high leads there, V5, V6 see the leads here, because V5, V6 are right here, right? My heart is right here, right? So they're looking here, whereas 1 AVL is looking right here. If I were to split my body in half, they're looking right here, 1 AVL, right? High lateral, whereas V5, V6 should be fifth intercostal space, mid-axillary, that's right here, right? So yeah, so this, you said this is a high lateral wall MI, left circumflex, and then what else? Do we need to do any other leads, any other fancy EKGs? No, we do not, because the only time you would do that is if you saw RCA involvement, 2-3 AVF, or you saw V1 through V3 ST depression, right? All right, so posterior wall MI is possible. It's like, I wouldn't guarantee that one. I say that would lead placement error. So I would say,
There's depression there.
but I mean, it's not going to hurt. I mean, but I bet this is pretty confirmatory when I have the reciprocal changes. So yeah, if V1 has a slight like 1 millimeter ST depression, but that's not nothing to write home about.
And then
Okay.
Is V2 elevated or just not?
V2, no, not really. It's also, I mean, you have to measure like looks like 1.5 boxes, right? Maybe 2 boxes at the most. And if you remember your ST elevation criteria, right? It's age 45 and above, I think, right? And male versus female. So males are 2.5, females are 2, right? And V2 and V3. So there's a lot of extra steps when you look at V2, V3. Everywhere else, though, it's what? How many millimeters? 3 boxes? No? Make sure I don't give you the wrong information. So I think it's 1.5, right? 1.5 up, and then it's going to be, so it'd be, you know, once you got 2 boxes, you know you for sure have ST elevation, right? Or is it 1 millimeter? I think it's 1 millimeter up and 0.5 down. Okay, all right, next one.
Sorry, for the corner right there, where it says AVL and then V5, what's that number?
V6, that's a 6, of course. Yes. Someone went right with my left hand, so good thing we were right with the right hand today. All right, so what's next? We got bottom left, our next group, right?
So we thought there was an anteroseptal.
So we don't have any limb leads here. We only got V leads, so that's a big clue. So we got some, yeah, we definitely have some ST elevation happening. It's going like all the way across, isn't it? That's a huge MI, maybe. But yeah, V1 through V5, I'm definitely including the, you know, that's definitely the LAD. It's all the components of the LAD, right? The left anterior descending artery is involved, and you can even argue that it might be like a high-grade block. It might be all the way up here, right? And at the left circumflex, you could say may be involved a little bit too, or it could just be lead placement, like they placed the V5 too close or something, right? So, but yeah, it's definitely LAD is involved, right? So that's probably the one the cardiologists go to first. They're going to go to the LAD. They see the V1 through V4 changes. They're going right there. Okay, so that's what kind of MI? Anteroseptal wall MI, right? We definitely lost the little septal depolarization of V1. V2 not so much. It's still there. That's interesting. All right, so yeah. So then what else? Do we need to do V7 to V10 or V4R fancy EKGs? No, there's no ST depression in V1 to V3 to assess posterior wall, and the 2-3 AVF is not involved, or the RCA is not involved. Okay, and then top right, what do you got?
Lateral wall.
It definitely have elevation and V4 also, V3, V2, yeah, it's arguable that's probably elevated. V1 not so much. And then you're saying you got some reciprocal changes over here? Good. So you got some ST depression. Over here, that's definite reciprocal changes. And this is, again, it's extending all the way into the LAD. So I think this is, again, probably an occlusion all the way up here. So we're seeing changes in the left circumflex and changes in the LAD areas. All right, so it's a huge MI. All right, so it's anteroseptal lateral wall MI. So it has all the things. Okay, and do you need to do anything else fancy like V4R or anything like that? No, 2-3 AVF is not involved, and V1 through V3 don't have ST depression. Okay, I put yes, but there's really no signs of it. Anyways, next one. So what do we got? This one, that was last year's answers. Either way, so what do you got here? Bottom right. Pericarditis. We got you're saying you got ST depression here? Yep. We got some 2-3 AVF elevation, and we also have V5, V6. That's concerning, right? So why would I have my left circumflex involved, and why would I have my RCA also down, right? That doesn't make sense. Why would both vessels be down? Usually a patient presents with one vessel occluded, right? They don't present with everything, right? Usually they'll go in, they might go to one of the systems, and they'll see that, oh, you got this one and that one, and they'll do like, but either way, this is not everything. Your whole heart is not shut down at this point. So this is where AVR is useful. Okay, so pericarditis, gotcha. All right, so what's next? Top left. Yep, we got ST changes here in V4, V5, V6 as well. We got reciprocal changes. Oh, it's continuing all the way over, right? You got, yeah, definitely in lead 3, we have reciprocal changes. Remember, contiguous leads are where you're looking for ST elevation. Reciprocal changes, you only need one lead to check that box. Okay, so we got reciprocal changes in lead 3, and we got ST elevation in 1 AVL, V5, V6, a little bit of V4. That might be lead placement error, but definitely, what kind of MI is this? It's the lateral wall MI. So again, if we have our aorta coming right here, and we have our LAD going down this way, we got our left circumflex going over this way, and we have little obtuse marginals coming off the circumflex. It's probably a blockage over in this direction, right? Because the obtuse marginals and the left circumflex are involved. Obtuse marginals feed the low lateral, left circumflex feeds the high lateral. So I got high lateral changes and I got low lateral changes. So that makes sense why I might have a blockage right there. Right? Do we need to do any other fancy EKGs? No. Okay. I don't know what I was smoking last year. This does make sense. All right. So anyways, so no, what's next? Bottom left.
We got anteroseptal.
Anteroseptal. Very good. So you got ST elevation here. Okay. Just V1, maybe the lead placement error, but definitely V2 through V4. Right? You got some 1 AVL elevation as well, right? And you could argue V5. So this looks like another big MI. Okay.
Or is that just a wavy baseline?
What's that? V6? That's probably not good lead placement, right? I don't know why that is such a low amplitude. So I mean, it doesn't look. It looks like it's there. So, but we definitely have V2 through V5 ST elevation, right? So now we're kind of involving. We're kind of up here and involving the left circumflex as well. Might be a little partial occlusion up top as well. All right. So that's a big MI. That's what's an anterolateral wall MI, right? Reciprocal changes, not so much. I don't see any. Do you? You can maybe argue lead 3.
I was going to say, I wrote down 3.
AVR depression.
There is. I mean, could it be pericarditis? You'd look at the symptoms as well, right? So yeah, so you could say you'd look at the symptoms as well, but it makes sense anatomically, right? So it makes sense that this is just following the pattern up here, right, where we have like a high grade block, very, very proximal. Okay, so anterolateral wall MI. All right, top right, what do you got there? What do you see?
Sorry, We messed up because we did the last one.
It's okay. So yeah, so it's my fault for not numbering these. So we got, but you do see changes in what? I'm seeing changes in V2, V3 looks suspicious, V4 even. Do I see reciprocal changes? I mean, maybe AVL, maybe a little bit on lead 1. You can maybe see it there. So this definitely looks like which vessel's involved.
RCA.
RCA? No, RCA feeds the 2,3 AVF, right? So the 2,3 AVF's not seeing really any changes. I mean, you can maybe argue that there's ST depression there. So this is in green there. We got what vessel feeds those leads, V1 through V4 or V2 to through 4 right now. Anteroseptal, good. Which vessel?
The LED.
LED. So I would say this is an anteroseptal wall, MI. Okay. Do we need to do any other fancy EKGs? No, I'm not seeing ST depression in V1 to V3 to necessitate a V7 to V10. And I'm not seeing 2,3 AVF changes to necessitate a V4R. Okay. All right. Anteroseptal wall MI. All right, bottom right. What do we got there?
We have inferior wall.
Good. We got 2,3 AVF are elevated for sure. Right. We got reciprocal changes. That's a check right there. Right. So we got reciprocal changes, but there's more. Right. As Billy Mays says. Right. We got V2, V3, ST depression. That's curious. Right. So if we look at, that tells me what's going on. You got that RCA doesn't only feed the inferior wall right here, right? It first takes it takes a churn right there for the RV, and it also feeds the PDA, right? So we need to do both. But this feels like it's a posterior wall, right? Because if I were to flip this EKG up right now, right, upside down and look at it through it, or if you take a picture of it and invert it and turn it around, it's ST elevation, right? If I flip this on its side and look at it through the page, it's going to be a ST elevation, right? So this is definitely posterior wall involvement. Is it involving the RV as well? That's what the V4R will tell me as well, right? So I throw the leads on the back, so I do an extended posterior wall evaluation, and then after that I put a lead on the right chest to see if there's a RV involvement. But this is screaming PDA, right? Public display of affection. Okay, so the RCA vessel is definitely involved. We know that. So when they go to cath lab, the vessel they're opening up first is the right side, right? They're going there first as a first stop, right? And if it's a huge blockage up top there, they're going to take care of the whole thing, right? So that's what we have here, a RCA that's occluded, causing a ST elevation 2,3 AVF, which makes sense. The RCA is occluded, that's what feeds 2,3 AVF, or the inferior wall. But also, we know that 80% of the time, the RCA feeds the posterior descending artery, or the posterior wall, right? So that's what we have we have this ST depression in V2 and V3, but if we were to flip it over, we would see that is also ST elevation. Okay, so if you look at your page right now, do you have it open right there? Which one is it?
It's this one.
Okay, so if you look at this one through the page, you can barely see because it's double-sided, but you'll see ST elevation there as well. Okay, do you see it? See the ST elevation? It's obvious now as we look through the page. And that's the trick in real life. But now everybody has an iPhone, so you take a picture of it and you flip it on your phone. All right, so top left, what is this?
We got maybe lateral wall.
Good, we got some lateral changes here, right? That's one AVL is the high lateral wall, but I'm also seeing V5, V6, V4, V3, V2. Is this? Yeah, so I would say anterolateral. So it's if here's my aorta right here, and here's my left circumflex this way, there's my LAD going this way. I would say it's probably a blockage right there, right? Not quite left main, but it's definitely right there at the junction, at the ostial junction. You'll see them right in their notes. Okay, so I'm getting left circumflex changes in the high lateral. I'm also getting low lateral changes, right? V5, V6, and my obtuse marginals, right? And I'm seeing LAD changes as well. And do I have reciprocal changes? Very good. Yep. Good, we got reciprocal changes, that confirms I got an MI, right? And then do we need to do another assessment for V4R and, the posterior wall? No, this is the LAD. LAD does not feed. Yeah, the left circumflex does. You could say, yeah, I do it on every patient, but it is it's not feeding. This is not. We don't see any RCA changes. That's what we would say that we would need to do V4R for sure. And do we need to do a posterior wall? No, we obviously have ST elevation there. You wouldn't have ST elevation on the front and ST elevation on the back, right? That doesn't make sense. Okay, I keep saying yes. I'm not sure what I was thinking. All right, anyways, next one, bottom left. Anteroseptal. So good. So we got definitely lost little septal, little depolarization there, and also got some. Could that be ST elevation? I don't know, but this is. That's for sure. That's for sure. That's for sure. That's for sure. All right. And then is there reciprocal changes in one AVL? Not really. There's not even ST elevation in one AVL. So I wouldn't say this is left circumflex at all, right? Because left circumflex can be high lateral or low lateral depending on where you are in it. If it's past the obtuse marginal, you could say it's just left circumflex. If it's before it, right? If it's here or here, right? If it's before proximally, you could say it's lateral wall for the whole thing. But that's not even involved at all. This looks like it's just purely LAD, right? Purely the LAD is blocking its flow to the septum underneath, right? You got the septum underneath and you got the anterior wall underneath. Okay, so this is anteroseptal wall MI, right? And then, do we need to do any other further assessment? Any other fancy EKGs? No. Okay. Anteroseptal wall MI. That's pretty straightforward. All right, top right. What do you got there? I don't know who it is. Who has it?
I think so. Right? You guys said you guys did one. You did.
All right. Well, we can do it together. It's fine. All right. So what do you got? I got some. ST changes here, ST changes here, ST changes there maybe, right? But this isn't making sense. Why am I getting widespread ST depression, right? In two different vessels, because 2,3 AVF is always the RCA. It's never anything else, right? I'm seeing V5, V6 ST changes. I'm seeing V3, V4 ST changes. You could argue maybe it's posterior wall, but this is widespread ST depression, all right? And are there reciprocal changes? I mean, look at AVR. That's technically reciprocal to everything else, right? So I'm seeing ST elevation in AVR. It's a bad sign. It usually means someone has a left main that's like almost 100% occluded with collaterals, right? So this is a what? It's a left main occlusion. Okay, it's a huge MI. So it's all the way up top. So we have this blockage all the way over here, right there at the between the aortic ostia and the LAD, left circumflex bifurcation. All right, so left main MI. So there's no reason to do another EKG. Is get to the chopper. Oh, get to the cabbage. That's what it says. All right, I'm letting myself laugh a year later. All right, and what else? Got bottom right.
We got inferior wall MI.
Inferior wall, yeah. We got some ST elevation there. Do we got reciprocal changes?
No. Oh, yeah.
I'd argue that's probably good. Yeah, that's reciprocal. Okay, ST depression there. We got ST elevation here for sure. Okay. And then anything else suspicious? Because 2,3 AVF should prompt you say, "Whoa, is there something else going on?" I'm not seeing that other thing, which is what? Over here there is no what? ST depression. So I don't really need to do a V7 to V10. Is it going to hurt? No, but I'm not seeing changes. This is probably a lesion that is where? So here's a PDA. PDA is not involved, right? But could it be the RV? It could, right? So we should probably do an RV assessment. Do a V4R, right? And inferior wall. So the blockage could be either here, right? Or here. And you're saying, well, if the blockage is here or here, then why isn't the PDA involved? There's 20% of the time, 1 in 5 times, it's the left circumflex that feeds the PDA, right? So this might be the left circumflex that's involved, that feeds it. But it could be if it's a proximal occlusion 40% of the time, right? Then it could be it could have RV involvement. So it makes sense to do a V4R to assess for ST elevation there. Okay. All right, next one, top left. Anteroseptal. So we're seeing changes where? We're seeing some ST elevation here. It's actually very little, but it's definitely, we're seeing some stuff going on. Definitely V1 and V2 for sure. We're seeing ST elevation, right? I'm not seeing anything in the other leads happening. So this is a, what kind of MI? Anteroseptal, you said? So what vessel is that?
LAD.
Yeah, it's LAD, right? Definitely it's affecting the V1, V2. That's definitely ST elevation there. This one maybe is arguable because, you know, you looked, usually the QRS would not come back down to baseline, but the V2 might have been placed incorrectly, might have been placed too low or something like that. So, you know, we have to think about human error sometimes. All right, but definitely septal wall is definitely involved, and that is fed by which vessel again? By the LAD, right? Do we need to do any kind of other fancy EKGs, a posterior wall or right ventricular wall? No, right? Because 2,3 AVF is not involved. Okay, so anteroseptal, I mean, I'd argue it might just be septal. All right, so then what's next? Bottom left.
Posterior, inferior, and MI.
Posterior, inferior. So definitely, I got ST depression, V1 to V3, even a little bit of V4. I mean, is that ST elevation there? I mean, it's not. Yeah, I got AVF in 2. That's contiguous. That checks out, right? So I got a blockage right here, right? RV, inferior wall, and then post PDA, right? Inferior wall, and I got my RV here. I do want to see if it's the RVs involved because this could be a blockage all the way up top, right? The blockage would be all the way up top, and the whole thing could be down. The RV, the inferior wall, and the posterior wall. That's a huge MI, right? Not only the right ventricle is not only affected, but the left ventricle is affected as well. The two walls of the left ventricle, the posterior wall and inferior wall. So we got to definitely do some quick another EKG. Look at the posterior wall, all right? And again, if you have your pages in front of you, you can flip it up and look behind it, and you're going to see that ST elevation, right? So yeah, this is a definitely posterior wall MI, but we got to see is there more involvement. All right, next one. What do you got there? Top right. Good. So we got V5, V6, even V4 a little bit, and then we got some 1 AVL, maybe AVL, but we got definitely have these lateral walls involved, and then I also got ST depression. What's going on there? What vessel is that? No, LAD feeds the anterior wall and the septum. If it was the LAD involved, we would see ST elevation in V1 to V4. We're seeing ST depression in V1 to V3. So if we're looking at the picture of it, here's our aorta, right? Off you come left circumflex over here. You got the LAD over here. But remember, left circumflex also feeds the PDA sometimes, right? 20% of the time, 1 in 5 people have a PDA fed by left circumflex. So this feels like we're getting a blockage right there, right? So therefore, we're going to see some obtuse marginal action. We're going to see some left circumflex action, and we're going to see some posterior action. That doesn't sound right, but anyways, we're going to have some, as we have ST depression going on, okay? And V1 to V3, and we're going to, which one of those, V4R or V7 to V10 is going to find my posterior wall? V7 to V10, right? All right, next one. What do you got there?
Anterior lateral MI.
Very good. That's prominent ST elevation. This one, not that much, but definitely V4 to V6. Definitely got some ST elevation happening over here. Again, this is probably, you know, if we're looking at our guy up top, it's probably blockage right there, right? It's blocking the LAD for sure, all right? And it's blocking the circumflex for sure. And it's here's our circumflex, and it's blocking the obtuse marginals for sure, right? So we have a high-grade block, really profound MI. Okay, anterolateral wall MI. All right, what about this one, top left? Left main, going fancy already. The way you know you have a left main is when you have ST elevation and AVR, right? And the way to confirm that, you'd see ST depression in most leads, right? I got ST depression here, 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 and there. Not so much posterior wall, but it's definitely in, well, why do I have 2-3 AVF and why do I have my left heart and my right heart not working, right? So that's a consideration that I have a huge MI. That's a, what kind of MI again? Left main MI, okay? All right, don't give, so you do an additional EKG, but don't give Plavix because they need a cabbage, right? Because Plavix lasts how long? The lifespan of a platelet is the right answer, but which is how long?
7 days.
About 7 days of the, 7 days. Usually they'll do the cabbage in 5 days, okay? All right, bottom left, what do those R's mean?
It's right side.
Those are right side EKG, so someone listened to my lecture, and that means they want to do what? They're looking for,
We put for the
really they went overboard. They did the whole thing. All you need is V4R, right? And we're seeing ST elevation for sure. So this is what kind of MI? Right ventricular MI, right? So which vessel was involved? Here's my aorta there. I got the what coming off of it? The RCA, right? First stop, RV. Second stop is my inferior wall, and the last stop is the PDA. There's no I don't know. I don't see the other EKGs. I can't tell you if there's PDA or not. All right, next one, top right.
Posterior.
So we got ST elevation over here. Why do you say it's posterior?
B1, B2, B3.
Yeah, this looks super sus, right? So we got some ST depression and V1 to V2, right? And I got my inferior wall again. They probably do have a PDA in this situation, and do they have an RV involvement? I don't know. It could be there, it could be here, right? We definitely know the inferior wall is involved, right? And we definitely know the PDA is involved, okay? And to confirm that, we would hit a V7 to V10 to assess that, and then we'd probably do a V4R to assess if the right ventricle is also involved, okay? All right, last one, bottom right.
So with the V2 as elevation, possibly like a septal.
You said V2?
Yeah.
Yeah, I got some septal wall depolarization there.
And then below depression on the.
That's not pericarditis. What'd you say?
On the lead 2 at the bottom.
Lead 2? I think it's just artifact. It's kind of moving around. That's just normal.
I was gonna say.
That's it.
That's all I saw.
Sometimes you get normal EKGs.